Bom, 18 horas em ponto, eu acho que a gente podia começar. Antes de iniciar, eu gostaria de agradecer a Sobrice pela oportunidade, agradecer também a Cirtex, que nos está proporcionando esse webinar com um convidado internacional, que eu tenho certeza que vai acrescentar muito a nossa experiência brasileira com esse tipo de terapêutica, que é a radioembolização. O nosso palestrante é o Dr. Alex Kim. Dr. Alex Kim é um professor associado de radiologia e chefe da radiologia intervencionista do Medstar Georgetown University. E eu gostaria também de acrescentar que o Dr. Alex Kim é um dos investigadores de um novo trabalho muito interessante, associação o tratamento com Y90 e a imunoterapia em pacientes portadores de carcinoma hepatocelular. O Dr. Alex vai nos habilitar com uma apresentação. A ideia foi discutir um pouquinho sobre o tratamento com ítrium nas metápáticas. A gente pode discutir um pouquinho também sobre carcinoma hepatocelular, mas a ideia é falar um pouquinho menos de carcinoma hepatocelular e falar de outros tipos de como as metástases e os tumores primários também, principalmente o colangiocarcinoma. Dr. Alex, welcome. It's a pleasure to have you here. You have an interesting audience with Brazilian interventional radiologists and even oncologists. And then the idea is to have your presentation, like we talked, and in the end, stop for some questions and some discussions. Please take your time, and one more time, thank you very much for your attention.
Sure, thank you for the invitation. It's a real great privilege to speak to you all today. I will just note that Dr. Nasser has a much better background than I do. So let me just go and share my screen here. All right, yeah, can you see this okay?
Yes.
All right, great. So, so I'm going to talk about Y90 radioembolization. My understanding is that, some of you in the audience have a pretty extensive practice. Some others of you are starting a practice in radioembolization. So I'm going to try to cover a lot of the basics and some of the more complex issues dealing with this topic. Here are my disclosures. So for the first part of the talk, I'm going to really talk about the therapy, what to look for in patient evaluation, for the actual treatment, specifically going over the mapping angiogram and the dosimetry component, and then what we do for their post-treatment care, their follow-up, what to look for, what complications to look for. Then I'll delve a little bit into the data review, focusing a lot on colorectal cancer and HCC, but review the literature that exists for other metastatic disease as well. And then finally, I'll touch a little bit on how Y90 radioembolization may play a role in modulating the immune system and stimulating the activity of various immunotherapy agents. So all of you in the audience know this. So Y90 radioembolization is a therapy that's designed to treat primary and secondary liver cancers. So it's intraarterial delivery of Y90, yttrium-90, bound to particles. And there are a lot of different names for it, right? So transarterial radioembolization or TARE, selective internal radiotherapy, or SIRT, Y90 radioembolization or Y90 RE. A lot of people use these interchangeably. And most of you and all of you in the audience probably understand the physiologic basis for Y90 and actually all intraarterial therapy. It has to do with the dual blood flow to the liver. Obviously, the portal venous system supplies the predominant supplier of blood to the liver, but the hepatic artery supplies about a quarter. However, when patients develop tumor in the liver, the hepatic artery becomes the dominant supplier to the tumor. So over 90, close to 100% of the blood supply to the tumor is thought to be derived from the hepatic artery. So that's why when we do an angiogram, we oftentimes see a picture like this. You can see my catheter in the common hepatic, left-right bifurcation. You can see contrast uptake in the tumor, showing the robust arterial supply to the tumor, whereas the background liver really doesn't have much perfuse retained contrast. So when we first see our patients, obviously we're going to do the patient evaluation. So, we're going to get baseline imaging, baseline lab values, and then at the time of evaluation, we're going to do the scheduling. And I think that really helps with communicating to your oncologist when they know when you're planning on treating the patient. That gives them a sense of when they need to hold and resume their systemic treatment. And this is something that you want to really engage your oncologist and talk to your oncologist about, because the regimen changes between the type of tumor the patients have and what line of treatment that they might be getting. We'll talk about treatment planning, and then the treatment, of course, and then the follow-up care, including what medications we give and when to order the labs and imaging. Now, when you first meet your patients, and we see all of our patients in clinic, I really want to understand what the treatment goals are for these patients. So, I have two big buckets in mind. Are they a palliative patient, which is the majority of the patients that I see, or are they a potential curative patient? So for a palliative patient, what are the goals? What are the treatment goals? Well, you want to try to reduce tumor burden, prolong time to tumor progression. But what you really want to do is you want to improve or maintain their quality of life. So that means using strategies to prolong time to tumor progression, but minimizing liver toxicity. And you also want to improve disease-related symptoms. So these are all important components to realize when you're thinking about the palliative patient. And I treat those patients very differently, and I approach those patients very differently than the ones who I think may potentially be curative. So patients who we could potentially downstage their disease for potential resection down the line, or if, in the case of HCC, patients who we could downstage for liver transplantation. So those patients, in terms of their treatment, their dosimetry, I treat those patients very differently than the palliative patient. So patient selection, I think every patient with primary or secondary liver cancers with liver dominant disease are a candidate for radioembolization. Patients should really have liver dominant disease, which means limited or no extrahepatic metastases. So what does limited extrahepatic disease mean? Well, if they have a couple of lesions in the bone, lymph nodes, some lung mets, I think that's acceptable. But the question you want to ask yourself is the liver disease going to affect the quality of life, or is that going to limit their, is that the disease burden that's going to limit their lifespan? So if it meets one of those two criteria, then I think radioembolization for any tumor type, any secondary liver cancers, could potentially play a role. The next thing I look at is how good functional status they have. Are they up, moving around? If they're napping half the day and they just can't get up and move around very much, not even participating in their normal daily activities, that's probably not a great patient to treat, at least to start off with. So someone who has pretty normal baseline activity or is mildly impaired is what I'm looking for. The next thing is I want to ensure that they have good hepatic reserve. And right now, we kind of have relatively crude ways to measure this. The general numbers people look at are the total bilirubin less than 2 milligrams per deciliter, or a serum albumin of greater than 3 grams per deciliter. There are some functional studies that people are looking at, like a HIDA scan and other nuclear medicine scans, that could give you maybe a little better estimate of the hepatic reserve. But right now, these are kind of the laboratory parameters are what we use. And obviously, you don't want to treat someone who's, at the end of their lifespan. So you want to have someone whose life expectancy is at least 3 months, hopefully more. So what are some contraindications? So poor hepatic reserve is a big no-no for me. So someone who has ascites, especially if it's a new onset ascites, history of encephalopathy, if they have a large amount of tumor, especially if it's spread around the liver. So if it's localized to one lobe or another, I think that's definitely treatable. But if you have multifocal disease and over half your liver is infiltrated with tumor, that's probably someone that you want to be very cautious with. And one of the things that I look for, especially for someone I think is potentially curative, is their functional liver remnant, so their FLR. And this is something that the liver surgeons use a lot to determine if a patient's eligible for tumor resection. So the general numbers are the FLR, if they have a normal liver, their FLR, meaning the territory that you're not treating with radiation, should be at least 25% of their normal liver. If it's somewhat compromised, then it's got to be at least 40%. This is largely based on the surgical literature. Patients who have biliary obstruction, you want to be very cautious of. Their bilirubin may be elevated, but also for potential infection risks, you want to be very cautious about. And prior radiation therapy to liver, you want to also be very cautious about. Radiation on radiation can potentially worsen their hepatic function and lead to liver failure. So once I've done the pre-procedural evaluation, I schedule them again for the mapping angiogram and either 1 or 2 Y90 treatments on the day that I see the patients. And then they come in for their mapping angiogram day. So what is the goal of the mapping angiogram? You want to do a thorough evaluation of the hepatic arterial anatomy to make sure that you could deliver the radiation particles safely, which means that you're looking at potential extrahepatic blood supply that could cause GI ulceration. The other thing that we use the mapping angiogram for is to identify perfused vascular territory. And we do that, and I'll talk a little bit about that. We use our mapping angiogram day to do our volumetric calculations to do the dosimetry. So what tools do we use? Standard 5 or 6 French vascular sheath. I prefer to use a sauce catheter, a 5 French sauce catheter for most of my mappings, and then either a 2.4 or a 2.8 prograde. The 2.8 obviously is going to give you a little bit better imaging quality, but if you have to coil off a small vessel, sometimes that can be a hindrance. So oftentimes I'll use a 2.4. I haven't noticed too much of a difference in the imaging quality between the 2 types of catheters. So for my first 200-300 mapping angiograms, I followed these steps almost step by step. And that was just so that I wouldn't miss anything, that I was providing care safely. So I would always start off with an SMA angiogram carried out to the portal venous space, look for a replaced right hepatic or some other aberrant variation, document that the portal vein is patent. And usually I'll do, 3 for 21, some prolonged long injection. Then I'll do a celiac angiogram, a short angiogram just to document and assess the central branches. And I oftentimes, even now, will just select the left gastric and do an angiogram. And this is the reason why I like using a sauce catheter, because when you pull down the sauce catheter, half the patients, it just selects the left gastric for you. And when you do an angiogram, oftentimes you'll be able to see the origin of the right gastric, which I think is essential to identify during all mapping angiograms. And then I'll just run down every named vessel. So common hepatic, GDA, hepatic proper, and then I'll do either the right or the left. And once I've done a right or a left angiogram, I'll do a cone beam CT. And I do that for every single one of my patients. And I think the cone beam CT is really invaluable. So what are some of the vessels that you want to try to identify during your mapping angiogram? I try to identify the origin of the right gastric artery in 100% of my patients. It's my opinion that all of the GI ulceration events, the majority of them come from the failure to identify a right gastric artery. You want to identify to see if a patient has supraduodenal artery, and I would say I see it maybe in 5%, probably less than 5% of my patients. Falciform artery, if you see one, the cystic artery, which people always have a question about, and then more aberrant vessels like an esophageal artery coming off the left. So this is what a typical right gastric artery looks like. So this is my sauce catheter in the celiac artery. It's actually a tip in the common hepatic. You can see that this patient had aberrant anatomy. So the right hepatic is missing from here. So the patient has a replaced right hepatic artery. You can see the gastroduodenal artery coming down here, and then this is the left hepatic artery. And I'll oftentimes just count the segments. So segment 2, segment 3, and then when you come down here, you see something that kind of makes this smiley face or a Nike swoosh sign. That's oftentimes originates at the base of the left hepatic artery. This is the right gastric artery. And you could interrogate this and see if you could see a collateral. Sometimes if the patient has a gastric bubble, you could see it running alongside the lesser curvature. So that's very helpful to see. But you want to try to identify this almost every time. So here's another angiogram. You can see my parent catheter. This time I used a Cobra with a microcatheter in. You can see the left and right bifurcation. And if you just make a habit of counting the segmental vessels, so this is segment 2, segment 3. Well, what's this? So another branch coming down at the base of the left hepatic artery, making this kind of a smiley face extending beyond. This is the right gastric artery. Now, the other thing I think that could potentially cause a number of the GI ulcerations is a supraduodenal artery. So oftentimes it's found in the right hepatic artery. And what I tell my trainees, what I tell my fellows is that all the vessels, if you're injecting from the right hepatic artery, should be going towards the right. And if you see something going against the grain, you have to interrogate that. Oftentimes, that's a supraduodenal artery. Sometimes it could be a segment 1 branch, but oftentimes that's a supraduodenal artery that you have to identify. And in this case, we did a cone beam CT, and you could see clearly this vessel coming in and perfusing part of the duodenum here. So you definitely want to identify that, because that could lead to duodenal ulceration. Falciform artery, again, this is aberrant anatomy. So this patient had a replaced left hepatic artery. You can see I try to coil off some of the gastrics. The falciform artery almost always comes off of the segment 4A branch and takes the straight medial path towards the umbilicus. If you identify this, not a huge deal. I just usually put ice packs around the umbilicus. I've never, as far as I'm aware, have had a patient who's developed skin ulceration from embolizing the falciform. And then this is a cystic artery, a little bit of an aberrant takeoff, but it has this typical pitchfork appearance. And one question that I get asked all the time is, what do you do about a cystic artery if it's prominent like this? Should you embolize this? Do you deliver radiation? What is the concern for radiation cholecystitis? Well, in the literature, the incidence of radiation cholecystitis is less than 3%. And in the papers where people have gone in and tried to embolize the cystic artery, the incidence of ischemic cholecystitis is about 3%. So, in my mind, there's really not a difference. I've treated plenty of cystic arteries. If you're really concerned about it, usually I'll give these patients about a 10-day course of Cipro. Probably just makes me feel better than really doing anything for itself. But I've had maybe less than 5 radiation-induced cholecystitises in my career. And then finally, occasionally you'll see a branch like this. This is from, again, a replaced left coming up straight towards the esophagus, pretty rarely seen. You just need to advance your microcatheter a little more distally, and you should still be able to treat this patient. So during the mapping angiogram, obviously you're going to inject your technician-labeled MAA. My standard is to inject 3 millicuries on the right side, 2 on the left side, and then in our center, patients always get a SPECT CT right afterwards. And this helps me do a couple of things. One is it gives me a rough estimate of the tumor to normal uptake ratio that I'm going to use for dosing purposes. And then it'll help me with the lung shunt fraction. So this is a coronal view of a SPECT CT on one of my patients. You can see all the radiation particles in here, very little in the lung. The lung shunt fraction in this patient was less than 2%. You always want to try to get a lung shunt study to reduce the risk of radiation pneumonitis. In literature, it's really less than 3%, so a very small fraction of patient. But if you have a high lung shunt, you want to make sure that your calculated dose of lung is less than 30 grays per treatment and less than 50 grays cumulative if you're doing bilobar treatments. So once you've done the mapping angiogram, as part of the mapping angiogram is trying to plan out how you're going to deliver the radiation to the patient. So different strategies. You could do a whole liver treatment. And when I say whole liver treatment, I don't mean from delivering from the common or the hepatic proper. I mean doing a split dose lobar, but treating the entire liver in a single day. I think if you treat from even the hepatic proper, you are putting the patient at a high risk for GI ulceration. And the initial studies in radioembolization where they actually did that, there was about a 10 to 15% of GI ulceration. So I would definitely recommend that if you're doing whole liver treatments that you do split dose for the lobar. The most typical strategy for patients with bilobar disease is to treat in a lobar fashion. So treat one lobe, the right lobe one day, and then about 4 to 6 weeks later, treat the contralateral lobe. If patient has unilobar disease, then you could certainly do a single lobar or a segmental treatment. What I've started to do more and more, and this isn't part of the IFU, and I'm not sure how many people do this, is I've started doing a lot more fractionated treatment. So calculating a dose that I want to deliver, cutting that in half, and then delivering that 2 weeks apart with the rationale that, that there's some potential liver toxicity benefits in doing a fractionated delivery in terms of the DNA damage recovery in normal cells versus tumor cells. And the first treatment of the fractionated method really serves as a second mapping angiogram for me. So I've had a number of patients that I've scheduled for 2 Y90 treatments, where after the first treatment, I'm not seeing much radiation uptake to tumor. I'm seeing a lot more in normal liver. I just cancel the second treatment, and that way I've significantly reduced the amount of radiation that's gone into the background liver. I want to make it clear that this is not the standard way that the majority of people would do it, and there isn't there isn't much literature to support this, but we've anecdotally had good experience in using this technique. So in terms of dosing, again, your treatment intent is very important. So again, the majority of the patients that I see, it's a palliative intent. They're having pain, or we want to try to slow down the progression of their disease. So the first thing on my mind is, is to minimize liver toxicity. First do no harm, right? So what I try to do is I want to try to calculate the dose so that I'm delivering at most 30 grays to a compromised liver. And this is based on SBRT data, where a dose over 30 grays was thought to be hepatotoxic. There is some IR literature to support this. So for patients who are on their 3rd, 4th line of chemotherapy with colorectal cancer, I do my very best to limit the dose to the normal liver to less than 30 grays. Now, again, If the patient is curative, ablative, if I'm leaving a lot of the normal liver untreated by radiation, then I'm trying to really deliver a high dose. I'm looking at a minimum of 100 gray to treatment area, sometimes 120, 150, depending on the size of the tumor and the type of disease. So these are kind of the standard methods of calculating the dose. There's the MERD method, in which essentially you're taking one area, you're not taking the tumor or the background liver into account. You're just saying all the radiation that I deliver into this compartment is going to get evenly distributed within this compartment. The BSA method, which is the standard way of dosing resin Y90, you're taking into account the patient's height, weight, liver fraction, tumor fraction, and calculating a dose based on their body surface area. And so that's the standard way. And then there's the partition method, which is similar to the MERD method, but you're also taking into account the tumor to normal ratio. So how much of the radiation is going to the tumor versus the background liver, and using that to calculate the dose that you think will get delivered to the tumor versus background liver. And I tend to use the partition method more than the BSA method. There's one other method that was used maybe 10 years ago. It's called the empiric method, where they just delivered a set amount of dose. That's been associated with a higher level of liver toxicity, so people have really moved away from that, and I wouldn't recommend that you use that method. So just kind of to illustrate this point, I'm going to show you a couple of cases, and I'll kind of go over my thought process in treating these patients. So this first patient is a 75-year-old male who initially presented to an outside hospital with fatigue and weakness. He noted that he had some tarry black stools for about a month prior to presentation. During the workup, a colonoscopy was performed, which demonstrated a large cecal mass, biopsy proven to be colonic adenocarcinoma. Staging workup demonstrated multiple liver masses, and then the biopsy was proven to be metastatic disease from this colonic primary. Because of the persistent bleeding, the patient actually did undergo a colonic resection that demonstrated a T3N1A disease, so 1 out of 25 lymph nodes were positive for disease. And the patient was started on FOLFIRI. Disease was relatively stable 6 months after treatment, and then was sent to me for consideration of radioembolization. So this is the kind of 2 representative CT scans across the liver for this patient. So you could see a couple of lesions on this cut, a larger lesion on the bottom. He had maybe 10 to 15 lesions throughout his liver, evenly spread between the right and the left lobes, not really a resection candidate. So I went and mapped him. This is from his MAA scan. So you could see a little more robust uptake in the areas of the tumor versus background liver. Sometimes it's really hard to calculate the tumor to normal uptake ratio from the MAA, but we knew that it was going to be more than the background liver. So what is my thought process in treating this patient? So this is a patient with multifocal disease. For all intents and purposes, a curative option isn't really available to him. So I'm going to treat his entire liver. He has relatively low tumor volume. And what I want to do is I want to minimize liver toxicity. He's on frontline therapy. He's done well. His disease isn't regressing, but it's stabilized. So I want to give him every chance to go on to get that second and third line systemic treatment, and then potentially do local treatments down the line as well. So I wanted to minimize the radiation to his background liver to, again, under this 30 gray threshold. So this is the Daver app. I'm not sure if it's available in Brazil, but this is a app that's devised by David Liu, who's an interventional radiologist in British Columbia, a brilliant guy. And he recognized that there was a need to have a calculator that could give you simultaneously what the dose would be if you were to use a MERD method, a BSA method, and a partition method. So for this patient, I decided to use a partition method, and I put in his height as 178, his weight, his liver volume, lung shunt. I put his tumor to normal ratio as 4 because I knew that there was a preferential uptake to tumor. And what I wanted to do was to deliver 60 grays to the tumor, which means that the background liver, I was going to deliver 15 grays. And again, I'm doing this in a fractionated fashion. So he's getting 15 grays times 2, so a maximum cumulative dose of 30 grays, and then maximum tumor dose of 120 grays. So why do I pick these numbers? So I think there's some thought that that more radiation is better, and that's true if you're able to focus that radiation to tumor only, which really isn't possible with radioembolization. So what we want to do is we want to see what is the lowest amount of radiation that we could give to get a tumor response while sparing your background liver as much as possible. And this is a really nice study done by a group in the Netherlands, where they looked at patients to see how much radiation dose embedded into tumor that was required to get a PET response 6 months after treatment. And what they found was that if you take their median curve and their 95% upper limit of 95% confidence interval, somewhere between a 40 and 60 gray to tumor was sufficient to get a PET response, meaning half of their glycolic uptake or the glycolic uptake in a PET scan was cut in half. So to me, this is kind of the minimum amount of radiation that you need to deliver to tumor to get a treatment response. So whenever I'm calculating a dose, I'm thinking about two numbers. Am I delivering less than 30 grays to the liver cumulative? And am I getting over 60 grays to tumor? And if the answer is yes, then I think that's a patient that would potentially benefit from radioembolization. So this is the patient's MRI that he had about 8 months after his treatment with me. So you could see nice regression of the tumor. So this is on the right. This is his baseline scan. So regression of the tumor up here, and then this larger lesion, again, a nice response to radioembolization. And again, the goal here isn't to cure him. You don't have to fry the liver. The goal is to palliate him, prevent tumor growth. If you get some CT MRI evidence of tumor shrinkage, that is great. But all I want to do is to prevent the tumor from growing for the next 6 to 12 months. That's my intent when I treat these patients. Now let's kind of look at the other side, which is someone who comes in with disease that I think I could really potentially cure. So this is radiation lobectomy, 74-year-old male with hep C cirrhosis, diagnosed with HCC based on imaging, no other major comorbidities, ECOG of 1, so a little functionally depleted, but pretty healthy, and good liver function. This is his MRI at time of presentation. And you could see that he has this fairly large lesion on the right side. There was a question of potential vascular involvement. So we had a multidisciplinary meeting where we discussed his care. And we thought really the best thing for this gentleman would be a potential resection versus transplantation. But there was some concern about the tumor size and the potential for vascular invasion. So we thought, well, what we could do is treat this patient with radioembolization, do a radiation lobectomy. And what it's going to serve two purposes. One, it's going to induce contralateral lobe hypertrophy for potential resection, reduced worry, concern of liver failure after liver resection. And two, it gives this patient a test of time to see how rapidly he would progress. So if he rapidly progressed despite radioembolization, he probably had disease to start off with. He wouldn't have to undergo the morbidity of a liver resection. So again, for this patient, is the remnant liver normal or compromised? He had hep C cirrhosis, so we can't say it's perfectly normal, but his Child-Pugh A, LFTs were pretty normal, so not too compromised as far as we could tell. But we were going to treat the entire right lobe. He had about 35 to 40% of the liver that we're not going to treat the entire left lobe, so we felt comfortable in giving him a very high dose. So in terms of dosimetry, this is how we attacked it. For this method, for a radiation lobectomy or a segmentectomy, I used the partition method, or essentially the MERD method. I'm assuming uniform distribution, which means that I set the tumor to normal ratio to 1, and then I set the target tumor dose to be at a minimum of 100 grays. And when we do so for this patient, the activity came out to be 3.7 gigabecquerel, so pretty hefty dose. You could see that the lung dose is below our 30 gray threshold, so this was safe to deliver, we thought. So that angiogram didn't show up, but this is his imaging actually 6 years after radiation lobectomy. He ended up not going to get a resection because he developed the ulnar met, but you could see how fibrotic and shrunk down his right lobe is. No evidence of disease. His left lobe has really hypertrophied. So, you talk about a 5-year survival, great long-term survival for this patient using radiation lobectomy. Unfortunately, he couldn't go get a surgical resection. But, I think we killed every tumor that was on the right side. Remember that tumor started out as about a 10-centimeter lesion. So really a tremendous response there. So when you look at radiation lobectomy, the concept of radiation lobectomy, what you're seeing is not only the volumetric hypertrophy, but you're also seeing functional improvement. So this is another study, I think from the same Dutch group, where they did radiation lobectomy, patients who underwent radiation lobectomy, and they performed HIDA scans before and after their radioembolization. I think it was about 6 months after radioembolization. And what they found was that for the volume, the overall volume seemed to be the same in patients who underwent radiation lobectomy. The treated lobe pre-treatment was larger than afterwards, as you would expect, and then the untreated liver hypertrophied compared to its baseline volumes. And when they did the functional scan, you could see, again, the treated liver, the function really decreased from the baseline, but the untreated liver really bounced up. So the untreated liver not only is hypertrophying, but it is compensating to some degree the function of the overall liver, the baseline liver function. You could see that post-radiation treatment, it doesn't quite get up to its baseline, but it's relatively close. So I think the concept of radiation lobectomy inducing contralateral hypertrophy is a good one in patients who have unilobar disease. And I tend to be very aggressive with those patients, deliver a very high dose of radiation to the disease side to try to eradicate the disease, knowing that I am, for the great majority of the patients, going to get adequate hypertrophy of the contralateral side, and the liver function is going to be sustained. Now, one of the questions that I'm often asked is about radiation segmentectomy. If you use resin, is that possible to do? And the short answer is yes, I do it fairly frequently. So this is an example, 45-year-old male with Hep B HCC. You can see he presented with this one lesion in segment 6. It's considered for liver resection. We did a transarterial liver biopsy, and the biopsy demonstrated stage 2 fibrosis, elevated portal systemic gradient, so not really a resection candidate. So what we did was we did a radiation segmentectomy, and you could see the MAA showing really robust uptake in the tumor. Now, one of the things that I think people get really worked up about with radiation segmentectomy using resin is, well, what if I reach stasis? You know, am I not delivering enough radiation? And that all depends on kind of how you calculate your dose, I think. So for me, what I do is I calculate the dose for the entire right lobe and deliver to a segment. And so of course I'm going to hit stasis, but I'm delivering 150, 200, 300 gray to the tumor. So it doesn't really matter if I hit stasis or not. I'm ultimately going to reach what I think is important, which is complete total necrosis with fibrosis, which is what this patient had. So, you know, I think sometimes people get worked up too much about hitting stasis with resin, when in fact, you are getting enough radiation in there to cause necrosis, which is really your ultimate intent. And I think now with the flex dosing, where you could get a hotter radiation per bead, the dose stasis really becomes a non-issue. So the final thing that I consider is, what is the treatment area that I'm treating? If it's a big tumor treating the entire liver, then I'll usually go with the standard dose. If I'm going for a radiation segmentectomy, I'm treating a small area, less than 300-400 cc's, then I'll do a 3-day flex dose so that I could have more radiation per particle. And I'm just able to deliver a higher amount of radiation to that area. Now, I alluded to earlier that we use our mapping angiogram and combing CT to do our dose calculation. So this was something that we published a couple of years ago, where we compared our patients where we used a combing CT volumetric technique to calculate dose versus using cross-sectional imaging. And you could see for this patient, we do a nice combing CT. The perfused volume is well outlined. We do use the software from the machine to calculate the volume. And what we found was that in a significant number of patients, you are seeing at least a 10% difference if you're using perfused volume. And in a small number of patients, the difference in the calculated activity between perfused imaging versus anatomic imaging is pretty significant. So, you know, I think if you are a routine combing CT user, I think it's worthwhile to investigate to see if you could use the software to really calculate the perfused volume rather than the anatomic volume. So what happens after their treatment? So initially, the first things that patients may complain about, in my experience, is really some fatigue. I tell my patients that the majority of patients will develop fatigue. You know, expect to kind of get back to baseline within a week or so, but a small number of patients can really have severe fatigue. About a third of the patients develop nausea or abdominal pain. Usually that's self-limiting, and patients go back to their baseline within a couple of days. Again, restarting systemic chemotherapy, a lot of that is going to depend on what agent the patient's on and your communication with the oncologist. But we generally start a couple of weeks, 2 to 3 weeks after the treatment is completed. And then at 4 weeks, we'll get a set of labs. If you routinely get PET scans, you'll see tumor response as early as 4 weeks. If you're using CT or MRI, you'll see responses usually later, about 3 to 4 months after treatment. For patients who develop gastric ulcer or radiation pneumonitis, you start to see this a month, 2 months after treatment. So if someone who's been doing great after radioembolization all of a sudden complains of abdominal pain, especially postprandial abdominal pain, so they're having pain after eating, you really want to get concerned about GI ulceration. You want to send them to the gastroenterologist to get scoped with a potential biopsy. And then REILD, which is radioembolization-induced liver dysfunction, you start seeing a little bit after that. So what do we do post-procedurally? So a lot of centers will do a steroid taper and a PPI, proton pump inhibitor. We have a slightly different regimen. I do a 2-month course of methylprednisolone, low dose, and I do 2 months of ursodeoxycholic acid. And this is based on guidelines that were published a few years back showing that this may minimize or reduce the incidence of radiation-induced liver toxicity after radioembolization. There are some papers that suggest that other drugs like pentoxifylline and low molecular weight heparin can also reduce liver toxicity. We don't generally use those. But all of our patients, great majority of our patients, we do steroids and urso for. I'm not a huge believer on proton pump inhibitors because the gastric ulceration that you develop from radiation is on the serosal surface and not the mucosal surface. So you know, I think it's fine to do if that's your standard. We generally don't do that. And then I'll order labs and imaging, labs in 1 month and imaging in 2 months, and every 2 months thereafter. And I'll usually communicate again with the medical oncologist to make sure that that we are obtaining imaging not separately, that we're collaborating on their follow-up imaging as well. All right, so now I'm going to jump to the clinical data. So again, as I talked about earlier, much of the Y90 data is in metastatic colorectal cancer and HCC, but there's a lot of smaller prospective studies and retrospective studies on just about any other secondary liver cancers that you could think of. And I think that makes sense, right? The rationale is the same. This is almost solely dependent on the preferential arterial flow to liver cancers. And that doesn't really matter if it's a metastatic RCC versus HCC. Now, you know, there are going to be some tumor types that are a little more radiosensitive than others, but at the doses that we're delivering, you know, you should be seeing responses in various tumor types. So we'll start off with metastatic colorectal cancer. And you know, I think it's very useful, and I think this is something that interventional radiologists don't often think of, is what cycle of treatment is my patient currently undergoing. So the best data of radioembolization for colorectal cancer is in the 3rd, 4th line, the chemorefractory phase. So I'll start off with that. So this is a study that was published in 2012, I believe. This is a multi-center phase 2 trial from Europe, where they studied 50 people with chemorefractory colorectal liver metastases, patients who were obviously unresectable. You could see the patient's characteristic here, so mostly good WHO performance status, good liver function. You could see that the majority had at least 25% of their liver replaced with tumor. And really important to note that every single one of these patients had at least 3 lines of prior chemotherapy. 75%, 76% had at least 4 lines of chemotherapy. So this is about as chemorefractory a population that you could think of. And what they found was that patients, about 3/4 of the patients were classified as responders. So it's actually stable disease or responding. So complete response, partial response, or stable disease. So 75% or so had disease control, and the remaining had progression of disease. And you can see that patients who had disease response had a really significant prolonged survival compared to the non-responders. So 16 months versus 8 months. Now, if you're thinking about the chemorefractory population, these are patients who really have 6 months to live, 8 months to live. If you're looking at the regorafenib data or the LONSURF data, and you've got to be careful in comparing across studies. So there's a limitation in that, but really that patient population, on the average, you're expecting to live 6 to 8 months. So getting a 16-month survival in that patient population is really tremendous. The second study that came out in 2010, this was actually a RCT, a phase 3 randomized controlled trial, again, performed in Europe, where they looked at infusional 5-FU alone or with radioembolization. And again, when you look at the response rates, you could see that the majority of patients who underwent radioembolization, they were able to achieve disease control or better, as opposed to only 35% of patients who underwent infusional 5-FU. And you could see that the time to progression in the liver specifically was much improved in the Y90 group as opposed to the 5-FU group. So you could, again, the time to progression in the liver and radioembolization was 5.5 months versus 2.1 months. When you look at the overall survival, there wasn't a significant difference between the two groups, but there are two caveats for that. One is that the study wasn't designed to look at overall survival as its primary endpoint. Its primary endpoint was time to tumor progression in the liver, which the endpoint which it met. And secondarily, about 50% of patients in the 5-FU group actually crossed over into and received radioembolization. So, I think this gives you a hint that radioembolization has the potential to improve overall survival in this patient population. It's certainly not conclusive, but given this, along with the prior data that I showed, I think it gives us confidence that in the chemo salvage, chemorefractory colorectal met population, that this might be a valuable treatment to the liver. And this is on top of large retrospective trials. So this is a multi-center study of about 550 patients, all with colorectal mets, where, again, for patients who have at least 4 lines of chemotherapy, 3 prior lines of chemotherapy, you're looking at a median survival of 8 months. So this is real-world experience showing a pretty robust response, especially in the chemo salvage patient population. And in the US, based on the existing literature, Y90 has been given an NCCN category 2A consensus recommendation. So not the category 1 where there are randomized controlled trials demonstrating survival advantage, but there is uniform consensus that intervention is appropriate for this patient population. So that's in the 3rd line and beyond. So the chemorefractory, heavily pre-treated patient population. What's the data for earlier in the process? So how about in the frontline setting? So the first study, I think this was a study from Australia in 2004, really when Y90 was really starting to be developed. They did a phase 2 RCT comparing Y90 plus systemic therapy versus systemic therapy alone for patients with advanced cancers. And you can see the patient characteristics were pretty similar in 2 groups. But note that this is a very small study, only about 20 patients in the study. And what they found was that the response rates were much higher in the Y90 group as opposed to the standard chemotherapy group. And you could see that the time to tumor progression was much prolonged in the Y90 group versus the systemic group. And in their study, in their cohort, they found a survival advantage in the Y90 group versus the systemic treatment group. Again, this is a study from 2004 or so, using an older line systemic regimen, but an interesting study nevertheless. And I think these types of studies led to the SURFLOX trial, which was a multi-center phase 3 study looking to incorporate Y90 in the frontline setting. It's patients were randomized to receive either FOLFOX plus or minus Avastin, or to get Y90 and then go on to get a lower dose of FOLFOX with a lower dose of oxaliplatin for 3 cycles, and then oxali plus Bev starting cycle 4 and on. The primary objective of the study was to assess for time to tumor progression. The endpoint was not met, but there was a benefit in progression in the liver. And you could see, sorry, I jumped through that slide, but the safety profile was very good for both arms. Now, the real definitive study is the Foxfire Global Study, which is actually a meta-analysis of 3 randomized controlled trials. This came out a couple of years ago. So this was about a very large study, 1,000-person study comparing Y90 in the frontline setting with chemotherapy versus chemotherapy alone. And I'm sure most of you are aware that this, again, did not meet its endpoint in terms of overall survival or progression-free survival. Similar to other studies, it showed that the time to tumor progression in the liver was improved in the Y90 group, but systemically, there was early progression in the Y90 group outside the liver. This may be a little tough to see on your slides, but generally the treatments were well tolerated with slight elevation in the Y90 group in terms of hematological toxicity. And in their subgroup analysis, they did find an interesting note that patients who had a right-sided primary seemed to derive a benefit from receiving Y90 in the frontline setting. You could see all of these other parameters kind of cross in the middle, and this is really the only outlier. So what does this mean? And this was a subsequent analysis where they further assessed this, and this was validated that there seemed to be a benefit in the right-sided primary when you use Y90 in the frontline setting. So what does this really mean? Well, I think it's been well established in both the surgical literature and the medical oncology literature that patients with right-sided colon cancers generally do worse. And there are different treatments for these types of patients. Some treatments are available for patients with left-sided tumors that are not available for right-sided tumors. So there is a need for other interventions for patients with right-sided primaries. I don't think with the Foxfire study you could conclude that Y90 should be given in the frontline setting for any patient with right-sided tumors, but it's certainly something that's worth considering. And at our center, we generally reserve those for patients who are younger, who have very heavy liver disease burden, who have right-sided primaries. Those are the patients that will consider incorporating Y90 in the frontline setting. And unfortunately, right now, we don't really have much data on the role of Y90 in the second-line setting. So, I think what we conclude is that the studies generally show that radioembolization can really lead to a robust liver response. So progression-free survival in the liver, you can prolong that using Y90 at any line. The data is highly suggestive that in the chemorefractory population, Y90 can not only lead to improved progression-free survival, but possibly overall survival in this setting. There doesn't seem to be an overall survival advantage of incorporating radioembolization in the frontline setting. However, there may be a benefit in the right-sided primaries, and that needs to be investigated further. But that's, that if you're choosing a patient population that you could potentially incorporate this in the frontline setting, that would be the patient population. And really, we don't have a great idea as to when to incorporate Y90 radioembolization. for colorectal cancer. I think in the chemorefractory setting, I think we have strong data to support the use. In the frontline setting, we don't have that, and I would caution using that, especially in patients with left-sided primaries. But what about second line? What about during the maintenance phase between first and second line treatments? And there's different rationales for using it in those settings. So I think, a patient who is has liver dominant disease that has toxicity from systemic chemotherapy, they just need a little break. We don't want the liver disease to progress rapidly during this break. Those are really patients that I think we could be more aggressive with treating earlier in their disease course. Next, we'll jump to the data for HCC. So there are a couple of studies looking at directly comparing radioembolization versus sorafenib for patients with advanced stage HCC. So the SERVNA study, which was performed in Asia, demonstrated no difference between the two groups. And the SERA study, which was performed in multi-centers in France, again, showed no benefit of Y90 over sorafenib in the advanced stage HCC population. So what does that mean? Does that mean that Y90 should not be used in the advanced setting? So I don't think so. I think there is a role for radioembolization for selected patients with advanced HCC. And I think this post-hoc study from the SERA study supports that. So this was a study where they selected patients from the SERA study that had limited tumor burden, so less than 25% of the liver replaced with tumor, that also had good liver function. So they had an ALBI score of 1. And what they found was that in the selected patient population, patients who were treated with radioembolization had a trend towards improved survival. So about 21, 22 months versus 17 months for patients treated with sorafenib. So I think in the selected group of patients where you have limited disease, again, kind of going back to that concept of functional liver remnant, if you're able to preserve a lot of the liver and deliver high doses of radiation to a limited part of the liver that's infiltrated by tumor, I think those patients are the patients, even with advanced disease, that could really benefit from radioembolization. So what about other tumor types? So there is increasing number of data looking at other primary and secondary liver cancer supporting the use of radioembolization. This was a recent paper that was published in JAMA Oncology, a phase 2 single-arm trial looking at the potential benefit of incorporating radioembolization plus systemic treatment in the frontline setting for intrahepatic cholangiocarcinoma. And you could see a pretty impressive median overall survival of 22 months, progression-free survival of 14 months. So this is a patient population that on the average lives about a year, 12 months or so. So really a robust overall survival. And patients who live for at least 2 years did really well in terms of tumor progression and overall survival. So a lot of these patients, I don't want to toss the word cure around, but they were able to induce long-term survival. And other tumor types, we've published our data in treating patients with pancreatic adenocarcinoma with radioembolization. Very small study, retrospective. However, we found that patients, again, in this patient population that doesn't have great treatment options, lived in the average of about 22 months. We followed this up with a multi-center analysis demonstrating similar findings. The median overall survival from diagnosis was 21 months, from time of radioembolization was 8 months. So some support for use in pancreatic adenocarcinoma, not at all definitive, but some rationale behind the use in that patient population. And again, if you look at the literature, there is some evidence to support the use for various tumor types, various secondary liver cancers. So large studies looking at neuroendocrine tumors, breast cancer metastases. This was a prospective phase 2 study looking at uveal melanoma and renal cell carcinoma. A lot of these studies suggesting that that radioembolization can potentially provide some benefit to these patient population. Again, the rationale behind the treatment is the same: preferential arterial supply to the tumor, relative increased dose to tumor while preserving background liver. That rationale exists for all of this disease processes. Before I move on to immunotherapy, I'll just touch on building a radioembolization program. I know a lot of you guys are in the starting process of building a program. And it really, in order to develop a robust program, you need multiple disciplines to come together to build a program. So not only is interventional radiology important, but you certainly need the support of medical oncologists, as well as surgical oncologists, radiation oncologists, and hepatologists, nuclear medicine physicians, and other groups. So really, this is really a team effort. And I think most importantly, if you're in the initial stages of starting up a program, it's really important to establish communication with the medical oncologist. And whether or not this is in a multidisciplinary tumor board, lunch and learn, grand rounds, or through collaborative research, the medical oncologist and you are going to work closely in identifying the best type of treatment for this patient, where, I think radioembolization can potentially play a big role. And a lot of the times, the medical oncologist is just not aware of radioembolization or the data that supports its use. So I think it's important that you bring up the existing data that you have and try to find patients who may benefit from these treatments. Okay, so the last part of the talk is going to be an immunotherapy and the potential synergy with radioembolization. This is a research interest of mine. And I think anybody who's involved in cancer care has to be interested in immunotherapy nowadays in one way or another. So, just generally, immunotherapy is just a method to amplify the body's immune response to attack and treat cancers. And there are a lot of different types of immunotherapies out there. There's the cellular base, including tumor-infiltrating lymphocyte, adaptive T cells, CAR T cells, vaccine therapy. I think what most people are the most familiar with are the pathway antagonists, specifically the checkpoint inhibitors. There are multiple checkpoint inhibitors in development. The two that are commercially available, two types, are the anti-CTLA-4 and the anti-PD-1 or anti-PD-L1 inhibitors. So essentially what these antibodies do is they block the inhibition of the T cell from acting against T cells. So these pathways, the CTLA pathways and the PD-1 pathways, I think of it as essentially inhibiting the functions of the T cells. It's obviously a lot more complex than that, but by administering an antibody against these receptors, you're inhibiting the inhibitor. And one of the reasons that I got really excited and interested in immunotherapy was because of my personal experience with patients. So this is a gentleman who I treated. So he actually presented to an outside hospital with a left lobe HCC. He underwent a resection and then presented to me maybe 6 months later with this. So you could see infiltrative disease, multifocal HCC throughout his liver. This is the coronal view, which may give you a better sense of the extent of disease. So you could see this white area is his tumor. So very infiltrative disease, other smaller sites throughout the liver. So he came to me and, I thought, well, his background liver is compromised. I'm concerned about delivering radioembolization to the entire liver. So I'm going to treat him with chemoembolization. So I went in and tried to do some chemoembolization. And this was his follow-up. Really, I caused some necrosis, but nothing to really be too proud of, right? You're still seeing a lot of viable disease, some central necrosis, but really this is what we see with chemoembolization for a setting like this, right? And on the coronal view, again, you kind of appreciate the extent of disease. So decent amount of necrosis, but still lots of infiltrative disease surrounding it. So I sent the patient to one of our oncologists. The patient was then enrolled in a clinical trial that we had running at the time and received atezolizumab, which is a PD-1, PD-L1 inhibitor, and bevacizumab, which is VEGF inhibitor, Avastin. And this is his imaging about 12 months later. So you could see very robust response. You could see a little bit of enhancement down here, but really the tumor had melted away in front of our eyes. And, I had never experienced anything like this. And after seeing this patient, I could understand why the oncologists were so excited about immunotherapy and checkpoint inhibitors. And this is the coronal view for this patient. You could see, basically his tumor has really melted away. And the results of that study actually was just published in the New England Journal of Medicine. And this was the first immunocombination in a phase 3 setting that was demonstrated to show an improved overall survival in patients with advanced stage HCC over sorafenib. So for patients with advanced stage HCC, this is now the standard of care, immunotherapy combination. So what does that mean? Why is that important to interventional radiologists and radioembolization? So although we see isolated cases like that where the tumor disappears, the fact is that for most patients with advanced solid organ cancers, immunotherapy really doesn't do much. So in this study, this was published maybe a decade ago now, where they looked at treating various tumor types with anti-PD-L1 antibodies. And you could see that patients with melanoma, some patients with melanoma and renal cell carcinoma, lung cancers, non-small cell lung cancers demonstrated some response. But patients with colorectal cancer, pancreatic cancer, gastric cancer, breast cancer really didn't benefit from checkpoint inhibition alone. So this, to me, is a really big opportunity for us. So, where does interventional radiology, where can we fit in treatment of these patients? So this is the immune cycle. And one of the reasons that Y90 and radiation therapy is potentially exciting is because radiation therapy can stimulate the immune response by not only secreting tumor-associated antigens, so sending foreign bodies for your immune cells to recognize and attack, but it could start the innate immune system by releasing various signals. It could lead to T-cell activation. It could lead to cytokine release. So radiation could potentially play a large role in augmenting the response to immunotherapy. This is just another slide that shows that radiotherapy locally to the liver can potentially stimulate the immune system to lead to response outside of your treatment field. And that's called the abscopal effect. So, to me as an interventional radiologist, the concept that your treatment of the liver can cause disease regression in the bone or the lung is a really exciting concept. And this is one type of, one example. This was published in JVIR from one of the interventional radiologists at Memorial Sloan Kettering in New York, where this patient with metastatic breast cancer underwent multiple lines of systemic treatment, various immune agonists and checkpoint inhibitors, received radioembolization, and then subsequently demonstrated abscopal effect outside the treatment field. So response in the pelvic nodes, in the neck nodes, tumor in the liver is gone. Unfortunately, 6 months later, the patient progressed, but this is really shows you the potential power of local therapy in inducing responses outside of your treatment field. Now, what is the data that supports the use of radioembolization with immunotherapy? There's one really interesting study that came out a couple of years ago. I think this was a group from Singapore, where they looked at patients who received radioembolization, then subsequently underwent a surgical resection or liver transplantation. And they looked to see the types of immune cells that infiltrated tumor. And in patients who responded very well to radioembolization, you saw all sorts of activated immune cells, NK cells, NKT cells, T cells infiltrating the tumor, suggesting that long-term durable response to radioembolization is maybe in large part related to the body's immune system, more so than any other effect. Recently at this year's ASCO, there are 2 studies that looked at combining radioembolization with various immuno-oncology therapies, various checkpoint inhibitors. This one was for HCC, so a phase 2 study looking at Y90 plus nivolumab. And what they found was they found an overall response rate of 31%, including 80% of target lesions in the radioembolization field, which regressed, which is really interesting because one of the, as I alluded to, one of the exciting things about combining immunotherapy to radioembolization is the potential to augment off-field effects. So, response outside of your radiation field. This data suggests that maybe the immuno-oncology treatments can lead to better responses locally as well. So that's something that needs to be further investigated. And there was a really preliminary phase 1 study looking at combining Y90 with immunotherapy combination for ocular melanoma. So this is an anti-CTLA-4 and a PD-1 inhibitor for ocular melanoma, and 3 patients had disease response. So we are currently the lead site at a multi-center phase 2 randomized controlled trial looking at this. So this is a study looking at radioembolization with or without combination immunotherapy. So the Tiso-Bev combination that was just published for advanced stage patients. We're looking to see if this could lead to durable response in a predominantly intermediate stage population. So we have 10 sites all within the US. We're looking to enroll 128 patients with the primary objective of progression-free survival. We've just, this study is going through our IRB approval this month. So we hope to enroll our first patients by the end of this month. So this will be hopefully an exciting data that we could present in a few years. And that is all I have. I'm happy to take any questions.
Thank you, Alex. Hard work. You sent us a wonderful overview of the Y90 treatment, and okay, if we have, I have many questions to you, but I will firstly give the opportunity for the audience to ask questions, and then let me see the audience questions. Okay, all of them are congratulating you for the presentation, and but the first question is, do you think there is a space for anti-reflux microcatheters for using with Y90?
Yeah, so that's a really interesting question. I've done some research with anti-reflux microcatheters, the Surefire device specifically. And I do think there is a role for anti-reflux microcatheters. There's published literature from the University of Tennessee that suggested a improved tumor to normal uptake benefit when using the Surefire catheter. It was a small study, but a really elegantly designed and well-performed study where they performed a mapping angiogram, giving low-dose MAA initially, and then in the same patient, giving high-dose MAA 6 hours later, using a standard microcatheter and followed by an anti-reflux catheter or vice versa. And in that study, they found that on the average, there was about a 60% increase in the radiation that was delivered to tumor. So I think that's an interesting concept. Obviously, that needs to be validated. In my personal experience, I do use anti-reflux microcatheters for certain patients, and that's usually for patients with bigger tumors. What I think happens, and I have some preliminary animal studies that suggest this, is that the anti-reflux catheters actually cause deeper penetration of particles. So if you look at the old pathology data from Andy Kennedy, when they looked at the explant specimen for patients who underwent liver resection after radioembolization, most of the particles were embedded in the periphery. You weren't really penetrating the tumor itself. In our preliminary animal study, we found that using an anti-reflux microcatheter can cause a deeper intratumoral penetration of particles. So what I oftentimes do, and in an endocatheter, there was more preferentially in the periphery. So what I generally do is, because I use the fractionated method for the first treatment, I'll use an anti-reflux microcatheter to get a deeper penetration of radiation more central into the tumor. And then the second treatment, I'll use a standard microcatheter to get the periphery. This is completely unproven, and this is something that I think that we have very limited data for, but that's how I tend to use this.
Yeah, I totally agree with you. And we've been using the anti-reflux catheter also for avoiding coil embolization. And we can,
Sure.
Yes, I think it's a good application too. Yeah.
Yeah, I would say the one thing about anti-reflux catheters is that you really need to aggressively flush the catheter with saline before you hook up to the vial, because sometimes you could have clumping and clogging of the microcatheter. So, you know, I really aggressively flush out the microcatheter before hooking it up to the Y90 system.
Okay. The second question is, in your experience, could TARE be done in an outpatient basis?
Yeah, so, you know, I work in an academic hospital. We do everything kind of traditional method, but I do know that there are a lot of outpatient practices that do this. So for us, you know, it's a same-day procedure. So patients come in, get their procedure done, 4 hours later, they go home. So it certainly can be done in an outpatient, as an outpatient basis.
Okay. There's a question from the audience. Can we treat patients with biliary obstruction relieved by metal stenting? There is a specific recommendation concerning avoid cholangitis.
Yeah, so that's a great question. So, you know, anytime you see biliary compromise, you have to be very careful. And there's a high incidence of liver abscess formation in that setting. So in the US, there are a couple of two different protocols that people use. One is the PEN protocol, where it's a complex regimen of bowel prep and multiple antibiotics, both oral or oral antibiotics before and after treatment. The more simple version in my mind is the method that Dan Brown came up with when he was at Jefferson, where he used, I think it was a quinolone for a few days before to 14 days after. So what I do is I've adapted that. I think in my mind, what you want to do is you want to sterilize the biliary tree before going in. So I do start 7 days before radioembolization, and I carry it through to 7 days after radioembolization. If you're thinking about doing radiation segmentectomy, there is a higher incidence of biliary sepsis, cholangitis, and abscess formation in patients with biliary compromise in that setting. So I would just be a little cautious for that.
Okay. Wonderful. There's an interesting question here. If a patient presents with sudden onset of jaundice and a tumor is diagnosed, do you think it's reasonable to perform a biliary drainage and then perform radioembolization without postponing the patient's treatment if the bilirubin levels drop? Do you understand the question?
Yeah. So yeah, I think it's reasonable. Again, the main concern there, I think the fact that the bilirubin level dropped suggests that you don't have long-lasting liver functional toxicity. But so again, you just want to be very careful about abscess formation, and so you want to do the longer antibiotic regimen. So that would be my main concern there.
Okay. There's a question maybe from an oncologist. Do you think is it safe to insert to someone who has been previously treated with dotatate lutetium from net liver mets?
Yeah, so that's something that we don't have a great answer for. As far as we know, in the lutetium studies, the rates of liver toxicity is very, very, very low, which makes sense because it's a receptor binding radiation treatment. And the studies that I've seen so far, which are small retrospective in nature, suggest that you can do Y90 before or after Lutathera. So I would say probably, but we don't have conclusive data.
Okay. There's, I think, another oncologist question. Why did you choose to use PFS in Y90 plus atezolizumab and bevacizumab in HCC patients? Does not correlate well with overall survival?
Yeah, so I think that's a good question. A lot of it was due to financial constraints. So if you're doing power analysis for a study like this using OS, you're just going to need to do a much larger study that was going to take much longer. So we used a surrogate for OS. And this is going to give us a signal as to whether or not a large phase 3 study looking at OS would be beneficial to do. And our sponsor, we discussed with our sponsor, and given the cost limitations, that was the direction that we went with. But yeah, I mean, I think ideally we would do a phase 3 RCT with OS as the primary endpoint.
Okay. Do you think is there a relation between tumor size or location and side effects when the intention is to treat with SIRT?
I haven't really noticed that. I'm not exactly sure what the question's alluding to. Like, are you talking about if the tumors right next to the bowel?
Yeah, I think he's asking about the side effects after treatment. Do you think the tumor size or location is related for a worse side effect or no?
Yeah, I haven't really noticed that. I think there's some correlation between patients' overall performance status and their overall tumor burden. So it's hard to see if some of the side effects that patients develop after Y90 is related to their tumor burden or radioembolization. But I haven't really noticed a clear correlation.
Okay. One interesting question here. Patients resected are sometimes referred for treatment in many centers. What is your opinion concerning avoid complications in patients like this?
Yeah, so resected patients, there are two potential issues. One is liver toxicity. So again, I just calculate, make sure that I don't go over 30 grays, depending on tumor burden, to background liver. And then if they've had, biliary reconstruction, then you worry about the infection aspect of it.
Okay. I have a question for you. So, many times when we are evaluating the image before treatment, we, especially in patients that was treated by chemotherapy, we've been seeing a lot of necrosis, tumor necrosis. What is your intention when you have a large necrosis in the tumor? Do you think you have to, because sometimes the oncologist said, I ask you, you have a huge necrosis. Do you think Y90 will work in a situation like this? What's your opinion? What's your comments about it?
Yeah, so I think it's just based on the tumor physiology. As the tumor gets larger, you're going to have central necrosis because you're not getting the arterial feeders centrally. But in the periphery of the tumor, you are going to get robust arterial supply. So that it makes sense to me to treat those patients because you're still going to get tumor embedding in the periphery where it is vascular. Now, in talking about dosimetry, it becomes a little more difficult. Then you have to think about how much of the tumor to include or exclude with your tumor dosimetry, and that becomes a little challenging. But in terms of treatment, I think it makes sense to do.
Okay. Here's a question regarding dosimetry. Do you calculate the TN ratio precisely, or do you use an estimate according to tumor thickness increased?
Yeah, unfortunately, we don't use, we have not yet measured it precisely. We are finally getting a software. I've been trying to get this in for about a couple of years now that will do voxel-based dosimetries from the SPECT-CT. So hopefully we'll be able to do the actual T to N ratios sometime in the near future, but we have not yet. The limitation of the partition method and calculating the T to N ratio is a couple of issues. One is that there are a number of studies that question whether or not MAA serves as a great surrogate for resin Y90. That's one issue. Two is that your T to N ratio can differ within a single patient amongst the different tumors. So how do you rectify that if your tumor in segment 5 is a 3-to-1, but segment 8 is a 8-to-1? What dosing strategy do you use? So I don't know that we'll be able to, even if you're doing a perfectly accurate T to N ratio, I don't know, how much that would necessarily add to the average multifocal patient.
Okay. Here's someone from the audience congratulating you for your presentation, and the question is concerning Nemesis trial and other studies. Do you think that CERT may take sorafenib's place treating HCC in advanced BCLC?
So I think that ship sailed with the latest data from the IMbrave 150 trial. The IMbrave 150, again, is the atezo-bev study that was published in New England Journal that really showed a much more robust benefit of immunotherapy combination over sorafenib. So I think it's going to be a very high bar to hit. I think studies like ours, where we're looking to incorporate Y90 with immunotherapy combinations, may be how this evolves. So if we get a signal that incorporating radioembolization with immunotherapy combination has a durable benefit in the intermediate stage patients, it certainly makes sense to try that combination in the advanced stage population. So for a lot of these disease processes, I think that makes more sense, doing Y90 in combination with immunotherapy rather than Y90 replacing the standard of care.
Okay. Alex, normally when you are calculating the BSA method, you can reduce your dose. Yeah. What's your approach reducing dose? What's the percentage, the minimal percentage that you reduce? In which situations you use the reduction dose to have your activity?
Yeah, so the classic scenario is a large person with a small liver. Those are the patient population where you can, using the BSA method, you probably are delivering a higher amount of radiation than what you need to. So for those patients, if you're using the BSA method, you certainly want to try to dose reduce 20–30%. And I think that's where the partition method comes in handy. You know, I'm not sure if you guys have the Daver app out there, but that's really a handy tool where you incorporate all those numbers and you could compare the dose that you would get from a partition method versus the BSA method. And if there's a large disparity between the two, then you really have to kind of think about why that is, and should I dose reduce from the BSA method or dose increase from the BSA method because the two numbers, the two values are not fitting.
Okay. Well, Alex, I'd like to thank you a lot. I appreciate your time sending us a wonderful discussion about Y90. And maybe once you could come to Brazil to visit us and to visit our centers. And one more time, thank you very much. I'd like to thank you and Sobrice and Sirtex for the opportunity. And I think that's it. I think you are very tired because of a hard work here.
That was great. Thank you for the invitation, and I would love to come down to Brazil at some point.
Okay. Thank you very much, Alex.
All right. Take care. Thank you, everyone.
Thank you, all the audience, and thank you, Sirtex and Sobrice. Have a good night, everyone.